In this video, I'm going to talk a bit about traditional Medicare. So under traditional Medicare, we have Part A, Part B, and Part D. So I'm going to start off by talking about Medicare Part A. This is coverage for hospitals, hospice, nursing home situations. Those are the general types of things that are covered by Medicare Part A. And Medicare Part A is paid for via the FICA taxes that are taken out of an employee's paycheck. Now, for Medicare, an interesting aspect of Medicare is that the um, number of days that are covered are measured relative to what are called benefit periods. So it's not relative to a calendar year, but what's called a benefit period. So let's define a benefit period. So a benefit period begins the first day of skilled services and ends after 60 consecutive days without more skilled care, and there is no limit to the number of benefit periods that you may have. So a person could have multiple benefit periods within a calendar year. Now, the reason why that's important is because deductibles are linked to benefit periods, not a calendar year. So if you could have multiple benefit periods within a year, someone is hospitalized for a period of time, then discharged, they're fine for a couple of months, and then they're hospitalized again. And so if it winds up being a separate benefit period, then a new round of deductibles applies in that case. Now, speaking of deductibles, for hospitalization, there is a deductible per benefit period. So the deductible kind of restarts if the benefit period restarts. Now, during days 1 to 60 of the benefit period, then the deductible only is what applies. Once you get past day 60 and you're in periods days 61 to 90, in that case, there is a coinsurance amount per day. And so the insured individual has to pay a coinsurance amount each day for days 61 to 90. Then, if there are days over 90, then in that case, those are considered to be what are called lifetime reserve days, and they have a higher coinsurance rate. So the amount of coinsurance actually bumps up. So basically, the longer a person is in a hospital or a hospice situation or so forth, sort of within a benefit period, the more expensive it gets. So if it's one contiguous benefit period, then what happens is during the first 60 days, it's only deductible. From day 61 to 90, then there's a coinsurance amount, then per day. And then once you get past 90, for days 91 and beyond, then that is basically a lifetime reserve day with a higher coinsurance amount. Now, there are a limited number of lifetime reserve days, and those lifetime reserve days are non-renewable. The reason why I'm noting the non-renewable is because there isn't a limit on the number of benefit periods, but there is a limit on the number of lifetime reserve days. So if a person has a whole series of separate benefit periods that only last, say, 30 days, then basically you don't hit the lifetime reserve days. You can have all kinds of benefit periods that are only lasting 30 days. But once you get over 90, you're using the lifetime reserve days, and there is a limited supply of those. Now, it gets a little bit more interesting. So those are the rules for hospitalization specifically. It gets a little bit more interesting for nursing facilities, and that the rules are just a little bit different. So for nursing facilities, and this is going to be triggered following at least 3 days of hospitalization. So the person has to have 3 days of hospitalization first. Then if they wind up at a nursing facility, then in that case, days 1 to 20 at the nursing facility have $0 of coinsurance. Days 21 to 100, there's a coinsurance amount per day. So basically if you think about kind of what this means is, in a very real sense, there's sort of an incentive for somebody to get out of the hospital and if possible, if they don't need hospital level of care, to essentially move into a nursing facility. So if they are hospitalized for a few days and they're, say a week or something like that, then the person is only subject to the deductible and we don't hit the coinsurance amount. And then if they get into the nursing facility for days 1 to 20, there's no coinsurance. So, if they triggered that, it was following at least 3 days of hospitalization. That's sort of the lower cost route. So there is sort of a financial incentive in some cases to kind of go that direction. Now, what does get kind of assuming that meets the needs that are necessary, that are required and so forth. So, interestingly, as far as insurance premiums, so insurance premiums charged for Medicare Part A, that's only going to be for those who are not otherwise eligible and who do not have the required 30 quarters of Medicare covered employment. So if you had 30 quarters of Medicare covered employment, then basically, if you go back to what I mentioned a little bit ago, Medicare Part A is paid for through FICA taxes. And so, the idea is basically you're only facing an insurance premium if you're not otherwise eligible for some reason, and you don't have the required quarters of covered employment. Now, significantly for Medicare, there is no maximum out-of-pocket limit. So you could keep going from benefit period to benefit period to benefit period. So if you had a whole series of very short benefit periods, um, and basically you have a benefit period, and then after 60 days of no needed additional skilled care, then you get another benefit period, and then you get another benefit period, and if it gets fabulously expensive or something like that, um, or probably more likely what would really result in a really expensive situation would be if you had a really, really, really long um, single benefit period probably would really trigger it because of the way the deductibles work and the coinsurance. So if you got into a period where you had months of coinsurance that you're dealing with, there's no cap on out-of-pocket expenses for Medicare Part A. So that's something that's worth noting. Now, Medicare Part B, this is physicians coverage. So Medicare Part A was all about hospitals and hospice and nursing homes, things like that. So think inpatient kind of facilities. Medicare Part B is optional, and this is going to be covering more like your visits to your physician and things like that. So for Medicare Part B, there's a deductible per year. And basically, Medicare Part B is going to cover 80% of approved charges. So emphasis on the word approved. So it doesn't mean it's going to pay 80% of everything. It's pays 80% of whatever's approved. And basically, what this is going to involve is, they might do like a wellness visit per year, things like that. So you have to find out exactly what's approved. But the basic idea is if it's approved, there are certain things that are covered. And there is going to be a monthly premium for Medicare Part B that might increase with higher income. So if you have a sufficiently high income, that premium could actually get higher. And if you are enrolled in Social Security when you sign up for Medicare, which wouldn't necessarily always be the case, because you'd be signing up for Medicare when you're turning 65, but you might not have taken Social Security yet. But if you are taking Social Security when you sign up for Medicare, then your monthly premium will be automatically taken out of your Social Security benefit for this. Now, if there are premium adjustments that are going to be invoked, then as it relates to that higher income, then basically there is a 2-year look back period that would affect potentially those premium adjustments. And again, as with Medicare Part A, Medicare Part B does not have any maximum out-of-pocket limit. So it covers a fair amount in terms of if it's an approved charge, pays 80% of it, but there's no limit on just how much the insured individual could wind up paying. Now, if you're looking at some of those and thinking, okay, so there are some gaps in coverage here, there's some things that aren't covered, things like that. Well, that's where Medigap coverage comes in. So Medigap coverage is basically additional insurance policy that can be purchased to fill the gaps in the Medicare coverage. Now, obviously, this comes at an additional cost, but interestingly, when enrolling in Part B at age 65, there is a 6-month open enrollment period. And then during that period, health status will not be something that can make the Medigap insurance provider refuse the policy. So basically, they can't refuse to write a policy when due to health status if you enroll during that open enrollment period when signing up for Part B at 65. So it's kind of worth noting there. But basically, the idea behind Medigap coverage is there are certain things that Medicare Parts A and B don't necessarily cover, and so the Medigap coverage can boost some of those coverages and provide a little bit more coverage at additional cost, of course. Now that brings us to Part D. So the Part D subsidy is basically a prescription drug coverage. So for prescription drug coverage, this is something that's the enrollment is available during the initial enrollment period. So when signing up for Medicare and you have the initial enrollment period, this is basically something that's available. There are deductibles associated with the Part D prescription drug coverage. There are co-payments and co-insurance amounts. Um, and there is a coverage gap until an out-of-pocket limit. So what that basically means is there are some limits there such that you're going to be paying basically out of pocket a certain amount until you hit the maximum basically there is a bit of a coverage gap there. So you have to make sure you're not going to it assuming it's going to pay for everything because it's not. Um, but there is basically kind of an aspect of that where there is a gap. And then eventually it's sort of a catastrophic phase. So really kind of what happens is sort of tiered. So basically you have sort of a deductible phase where you basically you're paying and it's counting towards your deductible, so you're just paying and they're not Part D coverage is not covering anything. And then you get to the co-payment, co-insurance, so the insurance is paying some and you're paying some. And then you get to a coverage gap period, and then basically with that coverage gap period, you're footing the bill until you hit the out-of-pocket limit. And once you hit the out-of-pocket limit, then you hit the catastrophic phase of coverage where more benefits basically kick in at that point. If things have gone really badly, basically. So that's kind of a brief overview of traditional Medicare Part A and Part B, and then how that kind of relates in with the Medicare Part D subsidy for the prescription coverage and so forth. If you're wondering about what happened to Medicare Part C, because we did A, B, and D, so if you're wondering about what happened to Part C, that's going to be the subject of my next video. So thank you so much for watching and have a great day.